So this guideline was an effort of multiple societies. It took approximately actually 5 years to come to fruition. American College of Chest Physicians has a very strict conflict of interest policy. They try to make sure that there are not influences from outside that are affecting scientific decision making, and the physicians are independent. And so, they followed that process. Then we looked at approximately 6,700 articles in this area, from which the panel members weaned down the articles to approximately total of 125, initially 108, then we added some more. And then we looked at those articles in great depth and detail. This area, one of the big problems with the area of neuromuscular diseases, actually there are two problems. One is that, as you were pointing out earlier, is associated with delayed diagnosis, can take years to diagnose. Two, particularly with ALS, an average ALS patient may live maybe 36 months after diagnosis, and every patient has their individual rate of progression of disease. So patient A may be completely different rate of progression than patient B. So you have to do a lot of individualization and also respect patient wishes. So we wanted to come up with a process and what to help with the management of patients. And what we did was we chose the guideline in a few key areas of respiratory management. Most of these patients, as they get weak, they are not able to breathe, so they run into complications from that. And then they have difficulty managing their salivary secretions. They are much more likely to go into the lungs. So they are much more likely to develop pneumonias and other problems, and likely to die from complications of that. So we wanted to provide the individual practicing clinician who, even as a specialist, like a general neurologist, a general pulmonologist, a pediatrician, an internist, a family physician, may only have a handful of these patients. Some mechanism, an area where they could look at and say, hey, let's manage patients with this weakness, neuromuscular weakness, this way to help improve outcomes. The first part of the guideline deals with testing, looking at pulmonary function testing. And what we ended up, we actually had some disagreements even amongst ourselves, because every disease progresses at a different rate. Some of the diseases in children progress much more slowly than somebody with ALS, who can progress much faster in 3 to 6 months. So we came up with a consensus of, testing every 6 months for the patients, based on just expert opinion and what we felt might be a reasonable compromise. And we also recommended to providers to start non-invasive ventilation, where you can use a mask or a bi-level positive airway pressure machine to improve ventilation early. We gave them criteria on how to start it early in the course of the illness without doing, sleep testing. So if we can avoid sending them to the sleep lab. We also provided indications on when to use the sleep lab and some recommendations. For example, if patients are going to a sleep lab in the community, it should be hopefully ADA compliant, and you may need some extra resources because this patient would probably come in a wheelchair, may need, transfer, need extra resources. That lab may not be able to do more than one patient. If they have this, often labs will have 2 patients at a time being managed by one technician overnight. They may not be able to do that. We provided guidance on how to initiate and some recommended general guidelines on therapy. There are other guidelines on details of how this is done. And then we provided input on when to transition from non-invasive ventilation that you can take off anytime to considering mechanical ventilation, where you'd have a tracheostomy and you'd be attached to a ventilator. And the big thing I want our general practicing physicians to remember, who are not focusing in this particular area, is the biggest thing is shared decision making, because this is a big decision. And even in our group, we had people who disagreed on when it should be started. We have people who feel like that it should never be started. And they manage their patients with masks throughout, right till the end of the illness. And there are people who feel like that, if you've gone beyond 16 hours of a day of having a mask on your face, that might be a point of time to consider. So we had those internal discussions, and we asked for shared decision making with patients and families. We also recommended to also discuss palliative care in some cases, as based on patients' wishes. And then we finally provided the best ways forward in managing secretions. One of the cheapest medications available is an anticholinergic agent like scopolamine. And we provided recommendations on how to manage that. And then, so there are two parts of secretion management. One is to decrease the amount of secretions, and two, how to help patients bring those secretions out so that they often don't have the force that they can generate to pull out those secretions. We provided some recommendations for that. And we are hopeful that, those machines often cost $5,000 or so, that a patient or a patient care representative or a practicing physician could show these guidelines to his peer and ask for help with getting these medications as a recommendation from, these devices as a recommendation from these experts. So those are, I think, the main things that people, both practicing physicians and the general public, need to know regarding the guideline.